Well, and I'd like to start by introducing our agenda for today. As you can see, we've got three major agenda items in addition to our executive director report. We're going to begin today's meeting with a presentation on the status of the Steward Health market transactions, and then a presentation and discussion related to our role in reviewing these transactions and discussion of that review by the Commission. We'll then preview the 2024 Healthcare Cost Trends Report and the policy recommendations, as you know, in preparation for our cost trends hearing in November. We want the commissioners to help us focus the recommendations for this year, given the findings. And then we're going to hear about the HPC's new Behavioral Health Workforce Center, which is funded by the Executive Office of Health and Human Services, and we're operating that in collaboration with the office, and have the opportunity to meet our newly hired director of the Behavioral Health Workforce Center, Amy Doyle. And then, as I said, to close out the meeting, our Executive Director, David Seltz, and Deputy Executive Director, Colleen Elstermeyer, will provide updates in the Executive Director's report. So with that, our first order of business is to vote on the minutes from our last board meeting, which was July 18th. And I'll turn to Colleen Elstermeyer, if you could walk us through that.
Absolutely, I'm happy to. But before I do that, I am going to turn it over to David Seltz for an exciting announcement.
Great.
Thank you, Colleen, and thank you, Madam Chair. And before we get to the minutes, this is a milestone meeting for the HPC because this meeting today is our 300th meeting of the HPC since 2012. We have been keeping track of all of our public meetings over the past 12 years, and this is number 300 for us. So over 12 years, we've had 300 public meetings, many of them in person, most of them in person, some of them on Zoom. These are all of our board meetings, all of our committee meetings. This does not actually include our cost trends hearings or our benchmark hearings. These are just our board meetings and committee meetings. And if you do the math, 300 meetings divided by 12 years, that works out to 25 meetings a year on average, or more than 2 meetings a month for 12 years. It is quite a milestone for us. Thank you, commissioners, for all of your work in helping us meet this mandate of public transparency. I think we have met that mandate in terms of the incredible work of this agency to have that many public meetings in that type of pace over 12 years. So an important milestone that we wanted to just take one moment to acknowledge and celebrate today. To another 300, hopefully it takes us a little bit longer to get to there. With that, I'll turn it over to Colleen to walk us through the minutes.
All right, great. Thanks, David. Quite the milestone. Feels like just yesterday, though. All right, I'm looking for any amendments to the minutes from July 18th, 2024. Seeing none, I would ask for a motion.
Motion.
And a second.
Second.
And I'm going to ask each commissioner present to vote, starting with Chair DeVoe.
I vote aye.
Vice Chair Cohen.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Castiel.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Master Giovanni.
Aye.
Commissioner McGregor.
I'm going to have to abstain. I wasn't in attendance.
Okay, thank you very much. Commissioner Kwasnick.
Aye.
And Undersecretary Sung.
Aye.
Great. Thank you so much. Okay, back to
you all.
you, Madam Chair.
Thank you. So let me turn it over to David Seltz to get us started on the discussion of the Steward healthcare market transactions.
Thank you. And thank you, commissioners. And Before I turn this over to Megan Wolf, who's going to lead this presentation and this update, I did want to spend just a few minutes teeing this up and providing a few of my own words and reflections on this important topic. You know, of course, we wanted to begin this meeting with this important update to you and the public on the ongoing dissolution, bankruptcy, and transfer of assets of Steward Healthcare. You know, save for the early months of the COVID-19 pandemic, this has been the most challenging and distressing moments facing our healthcare system that I can remember. And, you know, on a personal note, I would say one of the most discouraging episodes of my career. I spent this summer listening to hours of court proceedings out of Texas as real estate investment firms and Steward leadership, corporate leadership, argued for weeks over how to extract the last few remaining dollars out of these institutions in Massachusetts. And that was, well, just quite disheartening for all of us who care so much about these institutions, the healthcare workers who have been working in these institutions, some of them have been working there for decades, the communities and the patients they serve, and more broadly for those of us who care about the healthcare system in Massachusetts and work to make it better, and work to make it better for patients and the people that live here. Healthcare should be personal, and healthcare systems should put people first. The subsequent closure of Kearney and Neshoba hospitals by Steward Healthcare since our last meeting has had and continues to have a very painful impact on those communities and workers. And those closures will clearly have long-term impacts on cost, quality, access, and equity. I think we're already seeing some of those impacts. We're seeing it in the stories we're reading in the media every day. We're hearing about it from our friends and family members and community members. I live in South Boston. Anyone who lives in this area knows someone who's been impacted by the Kearney closure, and I expect the same for many, you know, in the surrounding areas around Neshoba. That's not to say that there are many people who are doing, putting incredible work to try to mitigate those negative impacts that are happening right now. People who are volunteering their time, who are working, the other providers in those areas to step up to meet those patient needs. There are community groups who are stepping up. The associations in our state, the Massachusetts Hospital Association, the health plans have stepped up in some ways, the DPH, the local groups, community health centers, you know, all of these groups in these areas are stepping up to try to mitigate these impacts. But we know that they are going to be there. And you know, as public officials consider what the next steps or alternative healthcare settings are going to be potentially for these sites, I just did want to say publicly that we at the HPC will make our data resources and our expertise available to those planning efforts around next steps at those sites. Thankfully, through the leadership of the governor and the work of Secretary Walsh, there were arrangements reached to transfer operations of many of the other facilities to local operators. And we will be updating you on these agreements and proposals today as they are currently before the Health Policy Commission for review. In addition, we also are reviewing the proposed sale of the Steward Medical Group and Stewardship Physician Network, which is also before us for review and which we'll discuss with you today. So I'm going to turn it over to Megan to walk through what has happened since our last board meeting, where we are with these particular proposals before us for review, I welcome your questions and your comments along the way in this presentation. These are all open reviews before us as we sit here today. And so I encourage and welcome your comments about what you would like to see us prioritize as we continue these reviews. But with that, I'll turn it over to Megan. Thank you for the opportunity to share a few words. Thank you.
Thank you, David. For today's meeting, we wanted to focus on giving you an update on where we are in the process of reviewing the sales of various parts of the Steward healthcare system to new buyers and providing you with some background on the information that is public about the potential sales. I will start by walking through a timeline of Steward events since our last board meeting in July. The HPC received material change notice filings for the sale of Stewardship Health, Inc., Steward's employed and contracting network physician group, to Rural Healthcare Group through its affiliated Brady Health buyer on August 15th. And on August 22nd, the bankruptcy court approved this sale. On August 31st, two of Steward's hospitals, Kearney and Neshoba Valley, closed with court approval after it was reported that they did not receive any qualified bids. On September 4th, the court approved the sale of the other 5 Steward hospitals in Massachusetts to 3 other buyers, St. Anne's and Morton Hospitals to Lifespan, St. Elizabeth's and Good Samaritan to Boston Medical Center, and the 2 campuses of Holy Family to Lawrence General. We received MCN filings for these 5 hospital acquisitions between September 6th and 10th, and we received an MCN filing related to the employment of physicians affiliated with St. Elizabeth's and Good Samaritan by BMC on September 16th. The parties filed emergency determination of need applications with the Department of Public Health for the hospital acquisitions on September 9th and 11th. We understand that the hospitals are hoping for a closing date of September 30th, and we were reviewing these MCNs as expeditiously as possible with that date in mind. Next slide, please. This map shows the location of the Steward hospitals involved in the current sales, in blue, and the hospitals of each acquirer. North of Boston in the squares, you can see the 2 Holy Family locations and Lawrence General Hospital, the proposed acquirer of these locations. In Boston and just south of Boston in the triangles, you can see St. Elizabeth's, Good Samaritan, and Boston Medical Center. And in southeastern Massachusetts in the circles, you can see Morton and St. Anne's, located to the east of Lifespan's 3 acute care hospitals across the border in Rhode Island. Rhode Island Hospital, Miriam Hospital, and Newport Hospital. Next slide, please. Our analysis of the potential impacts from each of these sales is still underway, but we want to provide some more detail about what is being proposed in each of the Steward transactions under our review. Because their asset purchase agreements were made public through the bankruptcy process, we are able to share publicly a bit more information about each of these transactions than we can normally share publicly in the course of our reviews, including the purchase prices. This slide describes the acquisition of St. Anne's and Morton by Lifespan, the largest healthcare system in Rhode Island. The sale was approved by the court for a purchase price of $175 million, much of which is expected to be used to purchase the real estate from Medical Properties Trust. The transaction is also anticipated to include employment of some of the physicians affiliated with St. Anne's and Morton. The parties stated in their filings that they expect the hospital would be operated in substantially the same way following the acquisition. Next slide, please. This slide describes the acquisition of Holy Family Hospital's 2 campuses in Methuen and Haverhill by Lawrence General Hospital, a community hospital in Lawrence. The sale was approved by the court for a purchase price of $28 million, much of which is again expected to be used to purchase the real estate from Medical Properties Trust. The transaction is also anticipated to include employment of some physicians affiliated with Holy Family. In its filing, Steward stated that Lawrence General intends to operate the hospital campuses in substantially the same way following the closing. Next slide, please. And this slide describes the 3 MCNs filed by Steward and Boston Medical Center for the acquisition by BMC of St. Elizabeth's Medical Center, a teaching hospital in Boston, and Good Samaritan Medical Center, a community hospital in Brockton, as well as employment of certain affiliated office-based and hospital-based physicians by BMC. The sale was approved by the court for a purchase price of $140 million, which again, we understand, much of which is expected to be used to purchase the real estate from Medical Properties Trust. In its filings, BMC stated that it is evaluating if any changes to healthcare services are necessary in connection with the transactions. Next slide, please. Finally, the HPC is also reviewing the proposed sale of Stewardship Health, Inc., a subsidiary of Steward Healthcare System and the parent of Steward Health Medical Group, which employs primary care physicians and other providers in Massachusetts and in 8 other states. The sale would also include Steward Healthcare Network, which is a provider contracting network. The sale of these entities to Brady Health Buyer, an affiliate of Rural Healthcare Group and subsidiary of private equity firm Kinderhook Industries, was approved by the court for a purchase price of $245 million. The sale does not include the real property leases held by Medical Properties Trust, but the agreement states that Steward will assist Rural Healthcare Group in negotiating new leases with MPT. The parties hope to close by October 30th, and as with the hospital transactions, the HPC is working expeditiously on its review. Next slide, please. This slide provides more details about Stewardship Health, Inc. Stewardship Health, Inc., as I mentioned previously, includes both employed physicians in Stewardship Health Medical Group and the broader physician contracting network, Steward Healthcare Network. As of January 2022, Steward's physician network was the 3rd largest contracting network in Massachusetts, with approximately 2,950 physicians reported into our Registration of Provider Organizations program in Steward's most recent final filing. Of these, approximately half were employed, approximately 400 were primary care physicians, and the vast majority were specialists. This total includes more than 500 Cape Cod physicians, which we understand are no longer contracting through Steward. We also understand that many of the hospitalists and office-based specialists affiliated with the Steward hospitals whose sales we are reviewing are expected to move to be employed by or contract through the acquiring systems. So the number of physicians who will remain in the network that Brady Health Buyer is proposing to acquire would be somewhat reduced. We are working to better understand these physician shifts in our review process. Next slide, please. As you can see by this map, there are stewardship physicians across Massachusetts, particularly in the eastern and southern areas, in many of the same geographies as the Steward hospitals. Next slide, please. A physician group acquisition of this size, with physicians in Massachusetts and 8 other states, will significantly increase Rural Healthcare Group's physician operations. As we describe on this slide, Rural Healthcare Group was created in 2022. It currently owns 17 primary care clinics in Tennessee and North Carolina, each with approximately 2 to 3 providers, including advanced practice providers. Rural Healthcare Group is a subsidiary of Kinderhook Industries, a private equity firm begun in 2003 that has raised a total of $8.5 billion in capital and has 7 active healthcare holdings. I will pause here. Kate will next walk through our process for reviewing notices of material change, including the Steward notices currently before us. But before I turn it over to her, are there any questions about what is being proposed, recognizing that our analyses are still underway, so we can't yet discuss findings on potential impacts?
One question, Megan. This acquisition includes the employees that are in the physicians' offices as well?
It includes primary care and specialists who have patient panels. But specialists in some office-based clinics that are affiliated with the hospitals will not be included in the physician sale.
Thank you.
Megan, do we know whether there's any other across the other states that rural healthcare is seeking to acquire? Is there any other monitoring regulatory review going on?
None that I'm aware of.
So it's on us.
There is a federal review that is ongoing as well.
Okay.
And in this process, what do we know about Kinderhook's or rural healthcare groups' long-term strategy and how this acquisition plays a part there. You know, what can we ask of them regarding how long they plan to sort of be in Massachusetts, how long they plan to hold this investment? What can we get out of them at this point?
We have the authority to ask all of those questions and more, and we are currently in discussions with the parties. We would be happy to share our findings from those discussions with you confidentially at another time.
But Commissioner, to put a point on it, those are the exact types of questions that we will be asking in the course of our review. And thank you for raising those.
Commissioner Blakeney?
Thank you. Megan, when we look at the physician practices, obviously the practice includes others besides physicians. Is this contract designed to take in the entire office and all of the employees and support personnel? Or what do we know about that? And I have a follow-up as well.
Sure. I think that is also an area of active inquiry for us and something we're very interested in. Would
Okay,
be happy to talk with you offline.
okay, thank you. And Megan, just a secondary question. I've asked the question several months ago, but I think it's worth asking again in the light of this new information. Are we able to look at or somehow predict the impact of this acquisition on physicians' inpatient privileges at our existing hospitals? What will happen? You know, St. Elizabeth's goes to BMC, but there's a Steward program already, inpatient services there. Is there anything yet that can be clarified, or are we still too early in the process?
That's also something that we will and are certainly asking about. I think
Okay.
The physicians are very important to the hospitals, and the hospitals are very important to the physicians. We have looked at referrals in both directions. You know, what percentage of visits for primary care patients of Steward physicians take place at Steward hospitals. And we've also looked at, you know, what percent of outpatient visits at Steward hospitals come from patients of Steward physicians. So we understand in both directions that they are very important referral sources. I would anticipate that they would not have an incentive to cut them off entirely, but certainly something that we're hoping to learn more about in our review.
Of course. Thank you very much, Megan.
Of course.
And one more thing, because you know, at this point, one of the things that I'm concerned about and frankly very nervous about is that even though the remaining Steward hospitals will be in the hands of nonprofit operators, which is, you know, that's encouraging. We're still looking at a for-profit acquisition of the physician group. And I want to know, what are the ways that we can hold them accountable for doing right by patients, doing right by the people of the Commonwealth? What are the ways that we'll be able to do that over time, you know, in the absence of oversight legislation, which hasn't been passed yet?
That is an excellent question. I think to partially answer your question, they certainly, once they are providers in Massachusetts, they would be subject to all of our reporting requirements. We could bring them into our cost trends hearings. They, you know, their spending would be analyzed in our performance review process to the extent that it were above the benchmark. So certainly in those cases, we will be watching them very closely. And in our review process, we'll certainly require some assurances that they do plan to work with us moving forward.
Okay, thank you.
Any other questions before we turn to the next step? And I'll add to what Megan just said, that the leadership of Kinderhook and Rural Health Group has been in discussions with the HPC, has indicated their interest in understanding our expectations of them along the lines that Megan just outlined, and has made it clear that they want to be understood, for their track record and their performance, knowing that there have been concerns in our state around private equity and what those investments mean and what it means for the long-term health of these organizations. So I do want to reflect that they have been in discussions and have been very willing to have those conversations.
Megan, you mentioned a September 30th deadline on the hospitals. What's the deadline? What's the projected closing on the rural healthcare?
They are aiming to close on October 30th.
So we have a little more time. Thank you.
Of course.
Any other questions? Okay, thank you, Megan.
Great. So we can go to the next slide. So thank you very much, Megan. And this transitions perfectly into these next few slides, which are really just a reminder of our regular material change notice process. So all of these various steward reviews are going through our normal process, which is summarized at a high level on this slide. So the material change notice process, as you all know, is a core part of the HPC's responsibility to foster a more affordable, accountable, and equitable healthcare market. So providers and provider organizations are required to submit notice to the HPC before any proposed material change to their operations or governance structure, subject to certain filing thresholds. Those notices, as you know, are public and posted to the HPC's website. We then have 30 days from when the notice and all related materials are completed to us to determine whether a given transaction is likely to have a significant impact on the Commonwealth's ability to meet the healthcare cost growth benchmark or on the competitive market. And if we determine that such an impact is likely and a lengthier review would be helpful, the HPC can initiate a full review called a cost and market impact review, which takes approximately 6 months. However, even without a full cost and market impact review or CMIR, the material change notice review process is itself quite a powerful tool. With the extensive data and analytic resources that are available to the HPC, we can actually do quite a lot to assess the potential impacts of a given transaction, even in a relatively short time frame. So I did want to just reassure our commissioners, we are very much hard at work on all of these analyses, even with the somewhat short time frames. The HPC's public reporting, including in public meetings like today's, are a very important tool to increase the transparency and accountability around major market changes. And so, going back to some of the questions that were just raised, it's really an important opportunity to encourage our market participants to minimize potential negative impacts and enhance the positive outcomes of any given change. And so while we don't have the authority to approve or block any transactions, our work can inform the way that these transactions move forward. And it is complementary to and can also inform work by other regulatory agencies, including partners here in the state or our federal partners. And as Megan noted, the state's Department of Public Health is currently reviewing the proposed Steward Hospital transactions at this time as well. On the next slide, you see a summary of the broad range of issues laid out in our statute that we look at in each of our reviews, including in this short material change notice review process. So as you see listed here, we look at factors relating to healthcare costs and market share, quality, access, health equity, and importantly, one statutory factor is other factors in the public interest, which provides us with the flexibility to tailor our review to the facts of each specific transaction. And so if there are particular areas of concern that commissioners or the public would like us to assess, we are always happy to hear that feedback from folks. And these include some of the types of issues that could come up in other types of reviews, like antitrust enforcement or the state's determination of need review. But our factors here are even broader than some of those. And the next slide simply shows the typical timeline for the material change notice review process. So as mentioned, we have 30 days from a completed notice to us to assess the likely impacts of a given transaction on healthcare costs and market functioning. And that notice is complete to us when we've had an opportunity to receive pertinent confidential details about a given change and the parties, including through receipt of any underlying transaction agreements. We also engage very closely with parties, generally having one or more conversations to make sure that we fully understand all the details of a proposal. And it also gives parties the opportunity to raise any pertinent issues for our review. We then generally follow that meeting or meetings with the parties with a focused request for any additional information or data that we need to assess potential impacts. However, recognizing the extensive data resources that Massachusetts has regarding the healthcare provider system, we can also rely pretty heavily on existing publicly available data resources, particularly for existing Massachusetts providers, with a bit more required of our out-of-state entities. But as Megan noted, we're very aware of the time constraints facing the potential acquirers of the different parts of the Steward system. So we've been going through all of these regular steps, but doing so at a quite speedy pace to do our work as expeditiously as we can, while recognizing the critical import of having a robust assessment by the state. Once we have received all necessary information from parties, we conduct our analyses of potential impacts across all of those factors. And then we brief HPC leadership and commissioners to determine whether a cost and market impact review is warranted, or whether it makes sense for the HPC to close its review and publicly report any findings at the next regularly scheduled board meeting. As I mentioned, as part of our review, we can ask that the parties make certain commitments or disclose certain information publicly. And I'll note that with each of the Steward parties currently, we are engaging in that back and forth with the parties. We're simultaneously running all of our analyses, and we expect to be in touch with commissioners on findings and recommendations very soon. And I'll pause there in case there are questions on the review process before I turn it back to David.
Commissioner Foley?
Thank you, and good afternoon. Good to see everybody. This is a very important topic, clearly, and there's so many moving pieces. It's hard to figure out exactly where to focus at the moment from my perspective. Clearly directly impacted with this, representing 5,000 workers across the Steward healthcare system. So it's just been a lot. Just within this capacity, just thinking about the review process and thinking about the factors that we take into consideration during that review process around cost, quality, and access. And, kind of, I think each of the transactions we looked at over the course of over 300 meetings, sometimes I think we hone in on the cost issue. Sometimes it's more on the quality or access, based upon the circumstances of the transaction. And although all are important, I think on this one in particular, where my focus is going to be is around access. That, we've seen with the closure of Kearney and Neshoba, and we'll see how, the impact on access to those communities, both very different in their healthcare needs, and the impacts are very different. But, with the remaining hospitals, there's been a line of services that's been provided and care that people come to rely on. And I think it's really important through this review process to really hone in on the access piece and what the service lines and plans, and if they have plans to change them, that they're really clear about that, what those impacts could be. And so I just want to reinforce clearly all those factors that we look at as a commission to move forward with these transactions are critically important, but sometimes one outweighs the other in the review. And I think in this one, it's really about access. And so I just would encourage in those conversations to be really clear about commitments to maintaining services in those communities. And if there are any plans to make those changes, that they're upfront about that in advance. So when we have the opportunity to look back and review, which, we've talked a lot about reviewing and looking back at some of the other transactions, which I do think we should get back to. I think there's been some significant transactions that we've reviewed and said we want to come back and ask those conversations. Did they maintain those commitments? I think this one is really around the access. So just want to make sure that as we're going through this process, that we really hone in on those questions and get clear commitments from the new providers of what service lines they're going to maintain. If they're going to make changes, let's have that discussion. I mean, I know we're going to have the conversation about our recommendations as a health policy commission about a healthcare plan. I mean, clearly this is a situation that illustrates we need a better way to plan for our healthcare services, what's needed throughout Massachusetts. And so being redundant, but I just want to emphasize that element of the review is going to be really important to me and to the communities these hospitals serve and folks have relied on for a really long time.
Thank you, Commissioner Foley. I want to let you know that that absolutely aligns with the priorities of the staff as we've been going through these reviews. I think these transactions are slightly different than our normal in that their counterfactual is different, that Steward will not be the owner of the hospitals or the physician group in a short period of time. And so maintaining access and a smooth transition to new operators is absolutely critical and something that we are focused on.
Thank you. Other questions or comments?
Deb, if I could ask, there's another hospital at play here, Norwood Hospital. Do we have any information or update on what's happening there?
Norwood was separate from the bankruptcy proceeding, so it is separate from this entire process.
Commissioner Blakeney?
Thank you, Madam Chair. Going back to a comment made previously, with looking at Kinderhook Industries, I hope we have the avenue to explore this company very aggressively in terms of looking at their past history. Commissioner McAllister raised the point earlier, but I'd like to reinforce it. Past is prelude to future, and it would be helpful to know their past history in terms of acquiring, especially healthcare organizations, and tracking the history of what happens during the time of that acquisition. I think it's very important to know that, and so I would encourage us through this process, if we have the wherewithal to do that, that we should take a very hard look at that. Thank you.
Thank you, Commissioner Blakeney. That is also a priority for us.
Other questions or discussion?
I have a question. If a red flag comes up in the process, what happens then? Does it come back to us? What's the process?
Yeah, so the process at this stage is that the HPC staff is getting as much information as we can. We're conducting the analyses, and then we report our findings back to HPC leadership and commissioners. So if we encountered a red flag, you would hear about it from us, and then there would be, it would be part of the decision-making process as to whether or not a cost and market impact review would be warranted.
Okay, great. Thank you.
Any other questions before we move to closing with David on this topic? I just want to, play back and confirm before we do that we understand the input of the commissioners around probing for details in terms of access, continuity, the understanding of these operators, some of whom are very well known to us and have provided services in the state, and some of whom would be new, and to just reinforce what the team has said about these questions being a priority and sharing the future information that we're finding in discussions as we, probe this, if there are any concerns that rise to the top.
Madam Chair, I also want to add that certainly I'm concerned, and I agree that I worry about what's happening in the communities, and who in particular is being affected. I worry about the 2 hospitals that have been closed, but also on top of all of that, what is the impact? And I know that that's not something that we're going to be able to do now, but what is the impact of that on all of healthcare overall? And I think about private entities that do exist, and from Worcester here that we have private entities. How is that, how is that moving forward? How is it going to affect our whole system, whether nonprofit or profit, but how is that going to affect? And maybe that's something to look at, but that's what I worry about also, along ultimately all the people that are being left behind.
Thank you.
So David, let me turn it over to you for any final closing comments on this topic.
Yes, thank you, Madam Chair. Madam Chair, I think you summed up this conversation very well. And commissioners, I appreciate all of your thoughts and guidance as we conduct these, really important reviews. Commissioner Foley, as you said, a lot of moving pieces all happening on a very on very short timelines, accelerated timelines, but we have, as an independent agency, a really important role to play here, an important role to examine these transactions, to provide objective information to the public about what we find, and we are hard at work to do that job and to do that well. The team is juggling many transactions at the same time. As you will hear later, we have more transactions before us at this particular moment than we have ever had in all of those 300 meetings in the 12 years of the HPC. But we have the right team, and we have the right experts that we have brought on board to be able to do this. And we need to be able to meet this moment as well, because there are a lot of questions, and the public is rightly trying to understand what the future will be here. And to the extent that we can help bring some clarity and some understanding or some commitments as we move forward, I think that is our role to play, and we will certainly do the best we can. So I look forward to bringing back more information to this entire board as we continue to move forward on these reviews, and to the public. So thank you. Yes.
Apologies, but if I may interject just really briefly, I know that some of the axes that will be explored in this analysis include equity, right? But is it possible to let us know explicitly sort of what dimensions of equity will be asked of this new company, Kinderhook and Rural Healthcare Network? Will they be asked about equity, race, clearly sort of racial and equity, and also equity along the lines of income and low wealth populations, geographic equity? How will we sort of hold them accountable in that regard as well? And as much explicit sort of questioning and information as we can get on that in that regard would be amazing.
Yes, thank you. Let's follow up on that, and I agree with you to be as explicit as possible, so that we can have accountability, right? Thank you. So with that, I think we can move forward off this agenda, and we will, I think, have an opportunity to talk a little bit more about this topic generally when we get to the end of this conversation, and think about our cost trends report recommendations, and where we see the need for some policy action given some of these cataclysmic changes that we've just been reviewing. So before we get there, though, I'm really excited to be able to turn this over to our research and cost trends team for our kind of annual big presentation where we get to share a bunch of research findings and data findings with you. This is the data nerd meeting of the year, where we're going to have a lot of information to share with you. So advancing on the next slide, just as a reminder, this is we're going to be sharing findings from our annual cost trends report. The cost trends report is mandated by state law that we issue an annual report focused on healthcare spending trends with any policy recommendations. This year's report, we have updated a number of analyses that we have done in years past with new data. We've also continued to evolve many of our methodologies and approaches to some of these analyses, and continue to expand our approach, methodological approach, to much of this work. We also this year have had a new, I think, increased focus on issues of affordability, which you'll see in some of the findings that we have here today. And we had a new focus this year on research around intensity of care in Massachusetts, which you'll hear about towards the end of this presentation. Today, we are just going to be sharing with you select findings from all of the different component pieces that we've been working on for really the last year in preparation for this report. On the next slide, you can see what the main topics are that are included in this year's report. So chapter 1 will be really around benchmark performance and affordability of care. Chapter 2, as I mentioned, is a new analysis around variation in treatment intensity. And then we have a set of chart packs that are focused on different topical areas. We are going to be going through highlights of each of these with you today. Subsequent to this meeting and this conversation, we're going to be sharing with you the full written report of the cost trends report for your input and for your feedback to us after this meeting. And then at the next regular board meeting, having incorporated your feedback and input into that written report, we'll bring forward the final report for your consideration and vote at the next board meeting. So really here today, we're really wanting to share our results with you and really get your reactions, your input, your questions to help us be able to shape the written report. And so really, we have a lot of content here. It's going to be a little dizzying, I'm sure, at certain points. So please use the raise your hand toggle so that we can interrupt the presenters. They do not mind being interrupted. They welcome being interrupted, and they really welcome answering questions on this work because they've been working on this really hard, and I'm sure would love to be able to engage with all of you in the weeds on all of this. So we've got a lot to get through, and I'm going to just turn it right over to our research director, David Auerbach, to get us going on this. So take it away, David.
All right. Thank you, David. I think that's right. I think my alternative title is Chief Data Nerd. And so we do have a lot of data today, and absolutely interrupt and ask questions. And I'm going to be joined by 2 members of my team for different parts of this, and we'll let you know when that comes. So here's the order of the presentation today. It's not exactly the order in the report itself, but these are the main topics. And let's go to the first section. And some of this is review. Some of this we saw at the benchmark hearing as well. But it's good to all be on the same page. Here is our 10-year performance against the benchmark. And on this graph, we've kind of broken it into 5-year segments where you can see for the first 5 years, the benchmark was 3.6. And on average for those years, we grew at 3.4%, just under. And in the most recent 5 years, the benchmark went down to 3.1, and our average annual growth was over that, was 4.0, with 5.8 in the very last year. And the benchmark will be going up to 3.6%, or already has in a sense, for 2023. Okay, next slide. For some of the analyses here, I should say we are going to be doing a lot of smoothing over 2019 to 2022. So we don't have the ups and downs of the pandemic. So that's what a lot of the trends I will be showing are, but I'll let you know if it's different than that. Here, 2019 to 2022, we're just showing that the commercial market has been the bigger driver of that growth than Medicare or Mass Health. And there's also been some enrollment changes, as we know, with the Mass Health redetermination or lack thereof, and big increases in Medicare Advantage, which is important to note. And that's happening everywhere in the country. Okay, next slide. And again, I will also be really focusing mostly on the commercial market for this presentation. This is showing our year-over-year growth in commercial spending trend, with Massachusetts in the orange. And as we know, we were below the US average in commercial growth from about 2013 to 2019. And that has not been the case since 2019, where our average annual growth has been 5.2%. Versus 3.8 in the rest of the country. And on the next slide, putting those same numbers, the 5.2 and the 3.8 in some additional context, the 5.2% growth in commercial healthcare spending is importantly greater than the growth in our income in the state for an average family. So healthcare spending, again, outpacing income growth, meaning more of the income is going to healthcare, and higher than the HPC benchmark for this 2019 to 22 period. And that's also faster than inflation grew in this 3-year time. Okay. And the next 2 slides really summarize some of the drivers of that 5.2% growth. Here we're comparing the 2019 to 22 period in blue to the period just a few years before that. And you see the 5.2% overall growth, faster than what we had a few years before. And the drivers of that growth, the pharmacy really stands out, of course, as growing much faster than in the previous period at 8.2% annually. Spending growth in the office, urgent care, retail settings slowed down, was not a big driver of the growth. And hospital spending was also a driver of this faster growth in the recent period. And subdividing that hospital spending on the right, you again see that the HOPD, the hospital outpatient, was much faster than ED and inpatient. But keep in mind that some of that lower inpatient and higher HOPD is due to a shift in quite a lot of surgeries shifting from inpatient to outpatient in this time. Most joint replacement surgeries in the commercial market have shifted from inpatient to outpatient. Okay, slide. And another important way we divide up this spending growth trend is prices and utilization. What you see on the left half is the total change in price over these 3 years for some of the common categories of care. And you see price increases over the 3 years, 10, 12, 13%. And of course, the prescription drug price increase is much higher. That's not accounting for rebates there, but all of these price increases really dominate. You don't see very much in terms of utilization. The utilization is pretty even. Small increases for some kinds of visits, and inpatient stays actually dropped over this 3-year period. So it's
A question. Oh,
price driven. Yes, please.
thank you. And a question from Commissioner Haupt.
Could we just go to the previous slide for a second? So David, you were talking about the switch in surgeries going to the HOPD versus the inpatient. Could you comment at all about pricing differential in moving that type of care?
Yeah, that's a good point. And we'll get to this much later, although I won't talk about it too much today. But in the report, we do focus on, in one of the examples, we look at knee replacement surgery. And with regard to that, it has mostly shifted from inpatient to outpatient over this time. And a typical inpatient price is on the order of $30,000, and it's more like $20,000 on the outpatient side. And so we show that the average cost of a knee replacement surgery has gone down, and that's reflecting this really big changeover by setting.
Okay.
So that's an example for you. Yeah.
Great. Thank you.
Can I just ask quickly too, just noticing the dates of this coverage, you're comparing, 2017, 19 to 19 to 22, which includes a lot of the COVID years. So how does that fit into the analysis? Kind of what do you see as some of the implications of that? Just kind of wondering again, we know we saw quick ups and downs and implications. I'm just wondering how we think about the impact of COVID on some of this.
Yeah, that's a good question. I mean, that's really why we're showing these numbers all show the average annual growth over the full time. And so it kind of smooths out the COVID, which was a big drop in 2020 and then a big increase in 2021. And then as we talk about in the cost trends report, when you go from 21 to 22, it's less affected by COVID. I wouldn't say it's unaffected, but I think smoothing out the 3-year period overall, COVID isn't a huge impact on some of these trends, but it depends. It depends for sure. But most of the things that we're showing, I would say it's not a huge factor in what we're seeing in these trends. And that's the point of the smoothing.
A quick question as well. Were ambulatory surgery centers at all included here? So for some of the
They are.
surgeries that shifted to outpatient settings? Okay, and would that be under the?
They're not in the, yeah, that's a great question. In this is such a high level grouping. The ambulatory surgery centers are in this data. I actually would have to go back and check with my team. I don't believe we count them in the hospital bin here, but I can get back to you with that. In the report, we break out the detail in much greater fine points, so you'll be able to see that.
Okay, sounds great. Thank you.
Yeah. Okay, so price and utilization trends, mostly price. And let's move on. And another one highlight on that really rapid increase in prescription drug spending that we saw. And we've shown this chart before, but updating to 2022, the average increase for a branded prescription over these 5 years now was 69% from 2017 to 2022, with 5% of prescriptions priced more than $6,300 in 2022. So that's a very high rate of growth. And in the cost trends report, we also do have and we showed this in some of the presentation a few months ago on GLP-1s, where we looked back at what was driving the prescription drug spending growth. And a lot of it was really coming from this one large category of immunosuppressants. And there's more detail on that in the report, including the impact of biosimilars. Okay, but that's what I wanted to cover in the broad spending trends, and just a couple notes on where this lands us with regard to premiums. Seeing that kind of spending growth, it's not surprising perhaps that our premiums ranked across the country have gone up since a few years ago. In 2023, our premium stood at $26,000 for a family coverage, and that was the second highest premium in the country after New Jersey, considerably above the US average, with 10% of those premiums more than $36,000. And on the next slide, when we take that average premium and then add in what a typical family spends out of pocket on healthcare, you're getting a total of more than $29,000 per year, which is the cost to insure, or the cost of healthcare for an average family in Massachusetts. That's $2,400 a month. And so we should have that number in mind. It's a very high amount of cost, and think about it in the context of the kinds of income and income trends that we have in the state. And so in the next section, what we do is take in all of that data and think about what is the impact on affordability of care. And we would expect an impact. And as we see on the next slide, we're fortunate to have 2023 data from CHIA's Mass Health Interview Survey. So we can compare affordability in 2021 and in 2023. And by really all of their measures, affordability has gotten worse. We'll focus on a few. So this is CHIA's combined measure from the survey of, do you have any affordability issue? any of the four, and those four are on the right. Do you have a high share of income spent on healthcare out of pocket? Any unmet needs due to cost? Problems paying medical bills? Any medical debt? And what we do in the graph here is we're dividing our privately insured population into those with income below 4 times the federal poverty level and those with income above that. And you see affordability issues getting worse in both segments. For the lower income folks, more than half report one of these 4 affordability issues at least. And for the higher income folks, more than a quarter have one of these affordability issues. And the next 2 slides take a deeper dive on a couple of these issues. This is the question of, did you not get needed healthcare because of cost? And in this case, we're focusing on, did you not get needed healthcare in 3 domains: a prescription drug, care from a doctor, or mental health care or counseling? So if you said yes to any of these 3 questions, you are counted as a yes here. And so again, with the same division of the population, you see a pretty significant increase in the population saying, I did not get needed care because of cost. And when you add those numbers up and put them in the context of the entire state population, that is growth from 600,000 residents to 900,000 residents in just the 2 years. It's 50% growth who reported that they did not get needed care because of cost. And on the right, I'm just noting that that share is higher among non-white residents than white residents in 2023. And then we'll take a deeper dive on the next slide into medical debt. And medical debt has gotten worse. There's more people with medical debt they're paying off, and the amount they're paying off is greater. And what we're showing there on the top bar is we're showing how much medical debt people are paying off. And if you are in this lower income bin, the proportion of folks paying off between $2,000 and $8,000 of medical debt in the blue has grown. The people with less than $2,000 in medical debt has shrunk. So you see that shift. And now there's even a significant segment of the population with more than $8,000 in medical debt that they are paying off, and some slight increases among the higher income group there. Okay, next slide. And finally, yes, let's stay there. A new survey, even from early 2004, asking residents of the state broader questions about healthcare costs and affordability. And that survey found that more than 2/3, I'm in the top left, were extremely concerned or very concerned about the cost of healthcare. They found that 40% of residents put off seeing a doctor or going to the hospital because of high costs. And when they were asked in the bottom left about, within the world of healthcare, what is the most concerning issue to you? What's the most important issue? Is it cost? Is it access? Is it quality? And by far, more people said cost was the most important healthcare issue that they faced, more than any other issue. And on the bottom right, when put against costs of other things or other concerns in the economy, healthcare was one of the top, just after inflation and housing as a concern. And people noted it was a growing concern since when they did this survey a couple of years ago. Okay, so that paints a picture of worsening affordability and more difficulty affording care and more people avoiding care. Okay, so now I'm going to move to our different chart packs in 4 segments, and I'll present the first 2, and then Yua will come in and present the primary care and behavioral health material. So it will be a quick nerdy dive through a bunch of slides. Starting out with our price section. And this is one of the most complex slides we have, but I want to walk us through it. What we're showing here is we're comparing prices paid to hospitals for, this is inpatient care, commercial sector, for an average complexity stay in 2022. And so this is a stay, it could be like a hernia repair or a diverticulitis or an average complexity hospital stay, and it's the same stay. How much would payers pay based on what hospital the stay took place in? And you see tremendous variation. There's always variation. Here, it's more than 2 to 1, from about 18,000 on the right to over 40,000 on the left for the same care. So that's the commercial payers, and that's commercial price variation. And what we're doing here that we haven't done before, which is interesting, is comparing that to what Medicare pays and what Mass Health pays for, again, basically the same stay. The Medicare, what we're calling Medicare full is in the yellow. That's Medicare, including the adjustments Medicare makes for teaching and for hospitals that serve a high proportion of uninsured or Medicaid patients. And one thing you see there, and the Mass Health is in the blue, is that the Mass Health and the Medicare rates are pretty similar. Sometimes the Mass Health pays more than Medicare, sometimes it's less. They're pretty similar with some exceptions for when Medicare is really paying quite a bit more with those hospitals with a high disproportionate share or with a high number of residents. That's where you see the spikes in those yellow for hospitals that get a high Medicare payment. So again, note the differences and the similarities in the different payers. And finally, I just want to say in the hospitals on the right, you will see that their commercial Medicare Mass Health payments are pretty similar. Some hospitals get pretty similar payments regardless of payer. And then they're quite different for some of the hospitals on the left. So these are all things to keep in mind, and they're important in thinking about the dynamics and the pricing of all payers and all providers. Okay. Now we'll move to some additional slides on price variation for different types of care. Here, we've talked about this in the past of clinician-administered drugs. There's price variation for drugs that are provided in a hospital or in a provider's office. Here's a common chemotherapy drug, Keytruda, where prices range from about $10,000 if it's administered in a physician office, or some hospitals to over $20,000 for other hospitals. So a variation of 2 to 1, which is really quite common. Next slide. We've also shown slides like this before where we're comparing prices by setting for some common services, colonoscopy, a lipid panel, Ocrevus, which is another clinician-administered drug. And you see on the bottom little circles that for all of these, they're most likely delivered in the HOPD, and the prices there are typically 50 to 100% higher than in labs or independent labs or in offices. Next slide. Here is our HOPD market basket, which we've shown before, of 50 common hospital outpatient services, the same basket. How much would it cost to get these 50 services at these different providers? And you see variation again of about 2 to 1, even more than 2 to 1 in this case. And finally, there is also variation by payer. Mostly what we've shown before is variation by provider, but payers do pay different amounts for some of these services. Variation is not quite as large, but it is there, and it's important to keep in mind. This is the price paid for that same HOPD market basket, and it depends on it differs by payer. Okay. So those are some highlights of the price variation section. Our next chart pack section is where we compare the performance of different provider organizations based on their patients that they see for their primary care, and what are the spending and utilization of those patients. Okay, let's move on. So first, starting out, we're showing variation in total spending for these patients for an average patient based on what provider organization you are attributed to. This is unadjusted. And we see variation of about 30% in 2022, and that is slightly higher than the variation in the early periods. So the variation is growing over time in the spending among the patients attributed to a provider organization. Okay, next slide.
So I just had a quick question on this slide.
Yes.
Just what pops out in my mind is, as you're looking at the spending by provider organization, it'd also be interesting to see on this slide, or some iteration of it, like the patient population that goes to within its provider organizations as well. As we're looking at the health equity lens through some of this work, it might be interesting to see those variations of spending from the 10,000 to the 7,000 and what the patient population looks like as a way to get at the health equity work that we're all embarking on.
Absolutely. I'm glad you asked that, because we anticipated that question perfectly. And so in this year's POPV chart pack, we do have a chart of about maybe 10 to 15 characteristics of those populations served by each of these groups. So you will see that, and they do vary. And we also show spending adjusted by health status in addition to this one, which is unadjusted.
Thank you.
Yeah. Okay. And now some of our utilization and performance outcomes. This one is ED visits. You see total ED visits per 1,000 patients in the blue and avoidable ED visits in the dark blue. And there's quite a bit of variation here across the provider groups of about 50% or even 100% in the avoidable ED visits. Okay. And next we have imaging, CT and MRI. CT is the blue and MRI is the orange, and there's about 30% variation across provider groups. This one is adjusted for health status as well. Okay. And here, to summarize, we show a number of 17 different low value care measures. And here, low value care spending is aggregated for all of those measures together. And we're just totaling low value care spending on all of those measures per 100 patients by provider org. And this graph is showing that spending arrayed from left to right. And as an additional feature, it is just showing the size of the patient population in the size of those bubbles. But that's not factoring into the dollars. The dollars are per 100 patients. And there's about 2-to-1 variation in that spending. And finally, we show new in this year's chart pack, we have a composite. So here you can see the 10 measures that we compare for provider orgs. And as sort of a guide to the eye, we're highlighting in blue where the organization had exemplary or significantly better than average performance. And there's a number of provider orgs you can see with a lot of blue. So that's just another way to summarize some of this massive amount of information. Okay, so that's a quick tour through provider organization performance. For the next chart pack, I will turn this over to Yua Wong on our team. Oh, question on the last part, I believe. Yes, please.
Yes, I was just curious as to what was considered low value care in these analyses. So what were some examples of some of the most common low value procedures?
Great question. And we've been expanding on our range of low value care measures over a number of years, and they're all taken from the literature. They're all well documented. And some examples are, a classic one is, I shouldn't use that word, but imaging for lower back pain. There are certain kinds of spinal injections. There are certain kinds of drugs that we know that are not helpful in certain clinical scenarios. Different kinds of imaging, preoperative lab tests that are known to have no benefit to patients. Those are some examples. Vitamin D testing is another classic one that we track. That has gone down, but it hasn't gone away in routine healthy patients.
Okay. Thank you.
Sure. Okay. Let's
Great.
move to, yeah, please.
Okay, I will highlight some of our findings from the behavioral health and primary care and behavioral health chart pack. I just want to acknowledge my colleagues Diana Vascones and Laura Nasuti, who also contributed to these analyses. So first, I want to start by showing some big picture trends in terms of primary care spending in the commercial population. We found that per member per year spending on primary care grew much slower compared to spending on other medical services from 2017 to 2022. Primary care grew about 12% in this 6-year period compared to other medical spending, which grew at almost 25%. In terms of when you count primary care spending as a percent of all commercial spending, which includes prescription drugs, that percent also declined from 8.5% in 2017 to 7.7% in 2022. Next slide, please. We know that there's payer variation on this. These are data from CHIA, which shows the percent of commercial spending devoted to primary care and behavioral health care. And you can see that the proportion range from 15.5% on the higher end to 8.7% on the lower end. Next slide. We also know that there is variation in terms of primary care use by population characteristics. Here we divided zip codes into deciles based on the median community income. And we looked at the percent of individuals that had no primary care visits. And you can see that in lower income areas, folks were much more likely to have no primary care use compared to residents living in higher incomes. And the difference is particularly stark among children. Children in the lowest income areas were 3 times as likely to have no primary care use compared to those in the highest income areas. And this is in part due to the fact that children in lower income areas were just more likely to have no care use whatsoever, whether that's medical or pharmacy. On the next slide, we conducted the same analysis looking at folks with no primary care use, but this time by the race and ethnicity makeup of the community. So we divided the zip codes into deciles based on the share of residents of color. And you can see here that in areas where the share of residents of color is higher, there tend to be a higher share of individuals that have no primary care use compared to areas with a lower share of residents of color. And on the next slide, I will highlight some of our findings in the behavioral health area. This analysis looks at ED boarding, which is defined as spending at least 12 hours in the ED. And if you look at the dark blue line here, which shows the proportion of mental health related ED patients that spend at least 12 hours in the ED, that rate is pretty close, still pretty close to 50% through September 2023. And the proportion of substance use disorder related ED patients that spend at least 12 hours, the rates have been somewhat stable during this time period. Next slide. Psychotherapy utilization. This is another area that we track. You can see here that telehealth, which is shown in the lighter shade of blue, telehealth ramped up in 2020 and has remained the predominant modality for psychotherapy, although the percent of visits that were through telehealth declined somewhat in 2022 compared to 2021. Of note, psychotherapy utilization was highest for young adults age 18 to 25, which are shown in the second set of the bars. You can see that their psychotherapy utilization doubled from 2018 to 2022. On the next slide, I believe this is my last slide, where we looked at mental health prescriptions. We found that the percent of all commercial members with at least one mental health prescription grew from 25.8% in 2018 to 28.6% in 2022. And this is true for all age groups that we looked at. You can see 4 age groups on this slide. But in particular, we found that the growth was biggest for young adults aged 18 to 25. The most common mental health prescriptions were antidepressants. So we looked at the use patterns for antidepressants as well. We found that more than 1 in 5 commercially insured adults filled at least one antidepressant prescription in 2022. And the growth, again, was biggest among young adults from 2018 to 2022. And with that, I will turn it back to David.
Okay.
Any questions before we move forward? Any questions from commissioners?
Yes, and I'm sorry, I can't raise my hand because I can't find where it is, but
No worries.
on that last, thank you. On that last slide, it would be interesting to know race and ethnicity here too. In these circumstances, who's actually getting these meds and who isn't?
Thank you.
And one other thought as if you'll bear with me reflecting back on the previous presentation, I'm thinking more about Dr. McGregor's question around the low value care. And I feel like it's going to be useful for us going forward to try to differentiate between the low value care that does not need to happen. You know, the examples that Dr. Auerbach gave, that there's nationally accepted understanding that certain clinical interventions don't provide benefit, and differentiate that from being in the wrong site of care. And the reason I think that's going to be helpful is because we're seeing, the organizations in our state grappling with access around the office visits, the sites of care that might be more appropriate, but that care is needed. And so the fact that it might be provided in an emergency department or another setting, to me, is a different phenomenon than it just shouldn't have happened at all. So I know that's tough to tease out, but I just think it's going to be useful for us to try to separate those two types of non-value, meaning needed but could have been in a lower cost setting, versus just isn't doing anybody any good. Does that make sense?
Yes. It does to me. And I think all of us, and the next section, I think will touch on a little bit of that too, with looking at avoidable hospital use, for example, that they are different but related phenomenon, and they're all important to keep track of. I totally agree. Okay. So let's move to the final chart pack section. In some context for this chart pack, and again, this has been true for a number of years, that when you look in, for example, the Commonwealth State scorecard of states where they rank us on a number of different dimensions, we're generally at the top in terms of healthy lives and prevention and categories like that. And this year we were 44th out of 50 in the category called avoidable hospital care and use. And it's just the one area that stands out where we don't tend to perform very well as a state. So some of the examples in this section will be about that. In this one, we're showing just our total use of hospital care, inpatient, outpatient, and ED, and the Massachusetts in the orange is above the US in all of these categories by the amounts you see on the right. And this was not always the case. In the early 2000s, our hospital use was similar to the US average. On the next slide, we're then going to show some different dimensions of this hospital use. For example, one fact that we've updated here, but we found this last year, was that part of what's driving our high use of hospital care is that we admit more of our ED patients to a full hospital stay than any other state. And here is showing among all payers that was true in 2020 as well as in 2019, of about 20% of patients admitted. On the next slide, we'll be turning to our Medicare data to make some of these comparisons in other areas. We have the second highest rate of hospitalization among Medicare beneficiaries. Overall, all hospitalizations, 15.5% above the national average in 2022. On the next slide, also the second highest rate of preventable hospitalization in our Medicare population, 28% above the national average. And then on the next slide, we continue to track our hospital 30-day readmission rate. Here we were the third highest in the country in 2022. And so some of these get at what you were saying, Deb, and some of these go back to having, robust primary care and, more of the settings that are lower acuity, that are helpful for patients, that can prevent a hospitalization. Okay, and then on the next slide, we're showing, so moving away from that, this is showing an aspect of the concentration of hospital care and consolidation in Massachusetts. What you're seeing is all of inpatient and outpatient care combined, and we're asking what % of it is delivered in different health systems in the state. This is 2022. And so you can see BILH, MGB, and so on. These are the largest systems. And when you take the top 5, for example, 62% of care takes place in the 5 largest systems in the state. And that's higher than it was in 2021 and higher than in any of the last 10 years, where it was about 48, 49% 10 years ago. So it's a way to observe that consolidation has continued to grow of care in a small number of systems. Okay. Now a few more, we're going to think about our post-acute care. This graph is tracking once somebody has had a hospital stay, where do they then go afterwards? The top line is showing routine where you're discharged to home. And then you can be discharged to home health or institutional care in the orange, which is skilled nursing or rehab or a few other settings. And so for the past years, the home health was growing quite gradually. We saw more and more home health and less institutional care. And that was a trend from 2017 to 2021, generally a favorable trend of less intensive care. And then we saw that home health percentage really drop from 21 to 23, as you see there. And that has been suggestive to us of, more about a lack of home health care workers. We reported this in our workforce report, and we know that sector is really just struggling to find aides and workers and a robust system to continue to provide that needed care. That probably explains some of the home health drop. And then in the next slide, we're going to focus on.
Could you sorry, is that all
Mhm.
payers?
Yes, this is all payers. Although
go ahead.
Yes. But keep in mind when we're looking at post-acute care, the majority of this is Medicare,
Yes.
is Medicare patients. That's right. Yeah.
Right, thanks.
Okay. Okay. So, right now on the next slide, we'll focus on skilled nursing facility. But on this slide, this is again highlighting bottlenecks and workforce shortages on the discharge end that are likely backing up patients into the hospital in terms of length of stay. So what you're seeing here is average hospital length of stay based on where you're discharged to in the same 3 categories as we just showed. So if you're discharged to home, routine care, you're on that yellow line in the bottom, length of stay has been pretty steady, even through the pandemic, just rising from 3.3 to 3.6 days on average. So not much of a difference. But where we really see the increase in length of stay that we all know about, it is mostly coming among patients who are then discharged to home health or to skilled nursing. That's where you see this big increase by about a day for home health, and even more than that for those discharged to skilled nursing. So these are, again, evidence of these bottlenecks keeping people in inpatient beds longer than they probably need to be in many cases. On the next slide, we're going to focus on that top line of the skilled nursing. We then broke that down by payer and said, how does that vary? Is there variation by payer? And you see that the increase is really the greatest in this long time trend in the commercial. So commercially insured patients ultimately discharged to skilled nursing, their length of stay in the hospital grew from 7 days to almost 12 by the end of this period. And David, I don't know if you have a comment about that, but that's an important trend, and it does relate to some of the dynamics that we see.
Is there a way to categorize the or account for the cost increase that would account for in our system?
The cost of
The longer length of stays, and if it.
Yeah, that's a good question. I mean, it generally shouldn't be impacting the cost that payers pay. If it's a DRG, that's a fixed amount per length of stay, but it certainly is an internal cost to the hospital of having that patient there in that bed. Now, I don't know if there are different variations where some payers might pay differentially by, special payments, but I'm not aware of that. It's possible, but this is mostly additional length of stay really a cost borne by the hospital.
Just to add a little bit of color commentary to this last section on hospital use and post-acute care, because I think these slides really resonate with some of the conversations that I have had as I've gone and talked to hospital leaders throughout the state in recent months. You know, they see both of these challenges. They see challenges of people coming into the hospital that they're trying to think of ways to provide alternative settings of care for them. So I've talked to hospital leaders who are focused on mobile integrated health and or setting up more urgent care, investing in primary care. Hospital leaders who are really thinking about hospital at home, thinking about any strategies that they can do to try to bring down that kind of influx of patients on the front door. And then they're also, I hear, just really challenged on this end as well, on the discharge side, specifically around discharging to post-acute care and skilled nursing facility. And we can see this in the data, this longer length of stay. And as what David just said, that becomes an internal cost to the hospital in many cases. And so, you know, I found this payer breakdown interesting, and I know, you know, that there have been efforts by both Mass Health and many of the commercial payers, maybe not all of the commercial payers. I know many of the local commercial payers. I would hope that some of the national commercial payers would do this as well. But on things like trying to relax some of the prior authorization, some of the paperwork and the rules that needs to happen in order to be able to place these people into skilled nursing facilities. But I've also heard that some of these are just really challenging circumstances. There are legal issues that go beyond the healthcare system. There are guardianship issues. And so there are a lot of people working on trying to untangle these bottlenecks. But these continue to be real challenges in our system, and both of these data points really resonated with what I think hospital leaders are struggling with. And Tim, I don't know if you're hearing this as well, but some of this continues to be around a workforce challenge, you know, throughout the system.
Yeah, I was gonna say, it's not just the home health side, it's also the long-term care space as well. And what do those two places have in common is relying on low-wage workers to provide that care, and folks can't afford to do that. So I think that, you know, the report we put out before about, you know, the impacts on that care worker is important consideration in all of this, is that, you know, long-term care facilities rely a lot on CNAs, which are low paid. We need more of them. There's bottlenecks of becoming a CNA, and there's obstacles to doing that, and the home care workforce as well. So I just think it's deal with all of those issues if we're going to address it.
Thank you.
David, I would just add that this includes behavioral health inpatient capacity as well, which is also impacted by the workforce issue.
Absolutely.
Okay.
I had a question about those last two charts around average length of stay increases. It looks like, I think I'm thinking about the previous slide where it really looks like there are some spikes, almost like seasonal spikes happening in 2020, 2021, 2022. And I don't know if there's any explanation from that. Are they COVID surges, or are people more likely to be, you know, sick and require longer stay in the winter? Does it have anything to do with the benefit? You know, do folks have more of a benefit at certain times a year? Is there any proposed explanation for some of those spikes? Because they really stand out.
They do. Oh, and now I'm going to have to change what I said to Tim earlier about COVID, but here you are absolutely seeing the COVID spikes of, you know, of spring 2020 and then the Omicron surge in early 2022. You know, a surge of people into the hospital, resulting in longer length of stay, crowding. That's right. That's right. And, you know, over 2023, you do see some of the length of stay trend moderating a little bit. And we're always tracking this. It's important.
Thank you.
So I think we are now ready for the last section, which is really exciting. We won't spend too long on it, but I'm going to invite Sasha in to present some of the material in this section. But let's introduce it. So this is a new chapter. Every year we analyze something different, something important and going on in healthcare. And what we wanted to talk about this year was the phenomenon of intensity of care. We often, as we did earlier today, break down our spending trends into price and utilization. And there's really something in between that's not perfectly captured by either of those. And it's insurers sometimes call this intensity of care, or researchers and clinicians. It's the phenomenon of there's a lot of healthcare problems or scenarios in which I could use a more resource intensive, a more invasive approach, or I could use a less intensive approach, thinking of like physical therapy versus a surgical intervention or something like that. And we wanted to understand this phenomenon because we know from the literature that there's a lot of variation. And, in particular, we see an increase in this kind of using more resources to treat the same patients. And it accounts for about 10 to 15% of healthcare spending growth that we've seen. So that's a motivation to, again, understand what's happening and where do we see variation in intensity of care applied. We do know from the literature that in some cases, using a more intense approach to treatment is absolutely warranted and better for the patient. And in some cases, it isn't. And it's hard to tell with the data that we have, but we're going to do our best to try to get a little bit of an understanding of this from some well-defined, well-studied scenarios. And we're inspired partly by the work of Zuri Song and others who looked at variation in a number of scenarios, often by individual physician, and they found a tremendous amount of variation for really the same sort of care. And they talk about some of why that is. And it's well known. There's a lot of reasons behind why providers may take a different approach. So on the next slide, again, to just introduce this, I'll show what our approach was to this topic. We thought very hard about trying to pick a few scenarios that had several characteristics. We wanted to find situations that were well documented where increased intensity or providers that are tending to use a more intense approach is not always associated with better health. And we also wanted to choose scenarios where they're common, there's a high volume, so that we were pretty sure we weren't looking at patient variation, because in the claims data, we don't always know everything you would know about a patient. And so, for that reason, we have to be, we're going to be guarded and couched in our recommendations and our understanding, but it's important to talk about, and we do see suggestive trends and patterns. And below are the scenarios that we look at in the cost trends report that you will see. The first one is what we'll show some results from today with Sasha, which is use of vaginal versus C-section delivery mode of birth. We also will talk about screening methods for colorectal cancer. We talk about treatment for knee osteoarthritis, thinking about physical therapy versus knee replacement versus arthroscopy, and use of cardiac catheterization. So the next several slides, and this is the end of the last section of our presentation, we will focus on the C-section delivery scenario. Okay, Sasha, go ahead.
Thank you, David. So as David introduced, a factor in health spending can be the intensity of care provided, especially when a health condition can reasonably be addressed with either more or less resource-intensive care. So we looked at the use of C-sections as a particularly high volume example of variation in treatment intensity. And here I want to credit our colleague Charlotte Burlingame, who led this analytic work. So C-sections are the most common surgical procedures in the US. And while they can be necessary and even life-saving for both patients and newborns, they also come with a higher risk of complications than vaginal deliveries and increase the risk of complications in future births, as well as the likelihood that future births will also need to be by C-section. In the US, about a third of births are via C-section, which is higher than the rate in other high-income countries and is actually double the optimal rate recommended by the WHO. Prior research has found that variation in C-section rates can be associated with a variety of non-clinical factors, such as use of continuous as opposed to intermittent fetal monitoring, physician discomfort with long labors, lack of use of nurse midwives, higher payments for C-sections, and unused operating room capacity. So this is, again, a very common service and one with a fair amount of hospital and physician discretion as to when it should be used. And as David described, we aren't equipped to indicate, or rather, we aren't equipped to assess the appropriateness of care provided to any individual patient, but discretion and wide variation indicates that in the aggregate, some amount of C-sections provided each year could have been avoided. On the next slide, we found that in Massachusetts, both all C-section deliveries as well as low-risk C-section deliveries increased notably from 21 to 2023. And in both cases, the Massachusetts rate now exceeds the national rate. Just to put a finer point on it, the Massachusetts C-section rate was below the US average from 2015 to 2019 and has been higher in recent years. And as of 2023, just over a third of all Massachusetts deliveries were via C-section, and of low-risk deliveries, 27.5% were via C-section. On the next slide, we see that the C-section rate is not, on the next slide, please, thank you. We see that the C-section rate is not uniformly high across all Massachusetts hospitals. We found substantial variation in the rate of C-sections for low-risk deliveries from 20%, or about 1 in 5 at the low end, to about a third, or 1 in 3 at the high end. In addition to this variation by hospital, we also found substantial variation in C-section rates by patient race and ethnicity, which is shown on the next slide. So while C-section rates rose for all groups from 2019 to 2023, they've been consistently higher for Black patients than for any other group. And this difference is not related to differences in chronic disease status or in other clinical risk factors. And I want to note that other researchers have likewise identified differences in C-section rates by race and ethnicity that are unrelated to clinical factors, including a recent study from New Jersey that found that Black patients were more likely to have C-section deliveries when hospitals had unused operating room capacity. That is, that the bar for moving Black patients to C-section would become very low and would be lower than for other patients when there was operating room space to do so. So we interpret this as indicating that non-clinical factors, such as the effect of structural racism and bias, may influence variation in C-section rates. And this is something that we're exploring in our ongoing work. So this is the end of this section of the presentation. So I would welcome any questions before turning it back to Director Seltz to discuss what's coming next for our cost trends report.
Okay, if no questions or comments for Sasha, then thank you so much.
Well, thank you, commissioners. Thank you, David, Sasha, and Yua for walking us through all of those findings. There is so much more, as you might imagine, in the report and all of these chart packs. As I said at the beginning, we're going to be sharing all of this information with you, commissioners, in the coming weeks as we prepare the final report for your consideration and vote at the next board meeting. We also will hope to bring some of these findings for discussion at an upcoming advisory council meeting and to be able to incorporate some of their feedback into the report as well, and hope to bring some of these themes into the annual healthcare cost trends hearing later this fall as well. So happy to take any final questions on this topic before we move into a conversation around our approach to this year's recommendations, which will be part of the report. Seeing none, I'm going to just move us right into that discussion. So as part of the report, every year we include a slate of policy recommendations. These recommendations are often recommendations to policymakers for reforms and changes that we recommend are necessary to be able to continue to advance our goals around cost containment, affordability, and health equity. On the next slide, you can see as a reminder, these were the 9 areas that we had made recommendations on in last year's report. I won't walk through all 9 of them with you today, but this was, again, a very robust set of recommendations. I will share in reflecting over the last few years, these recommendations have been relatively similar for about the last, I would say, 3 or 4 years in terms of the main topical areas that the Commission has been advancing, areas such as improving the benchmark, constraining provider pricing, administrative complexity, focusing on workforce. Many of these issues were contemplated as part of legislation that was under consideration by both the House and Senate at the end of this past legislative session. We have advanced these recommendations, as I said, many years in a row. These recommendations, I do believe, are well known to the policymakers and to others who follow our work closely. And many of them really do at this stage require legislative action to be able to move them forward. There are some that we will continue to and have continued to push forward with whatever tools that we have in our power. So as we were thinking about our approach for including recommendations in this year's report, I wanted to share with you an approach and a concept for discussion today that would be a little bit different than this list of 9 different recommendations. And this is really building off of the conversation that we started today's meeting with, which is really a reflection of this moment that we find ourselves here in Massachusetts, and an opportunity for the Health Policy Commission to make our statement about where Massachusetts needs to go next and what changes are needed. Next slide, please. So I'll just lay out some concepts here briefly, and then really we'll open this up for conversation and for your reactions and feedback. To be clear, we are not here today to decide this final recommendation. This is really an opportunity for conversation. We will work on these recommendations in the coming weeks and come back at the next board meeting to finalize this. So really do welcome all of your thoughts. But reflecting on this moment, and as we've written here, the bankruptcy of Steward Healthcare has created a really unprecedented crisis in our system. And we have at the HPC a unique role and expertise as a healthcare monitor, as a watchdog in this market. And that there is an opportunity to focus our recommendations this year on addressing the causes and consequences of this situation and crisis. I've laid out here that we could advance a recommended platform of reforms and policy changes that I think would be welcome to policymakers and to the public, necessary to achieve a number of goals, some of which I've laid out here for consideration. Protecting our system from predatory actors, strengthening public accountability and transparency, including on private equity investors, confronting and dealing with some of the underlying dysfunctions in our healthcare system that has created the environment for some of those predatory actors to come into our state, and that have led to a drive to consolidation, and to have a path forward, to have a plan, a transparent plan that will have a system where the supply meets the needs of the patients, where we are creating a system that is affordable and equitable and that has principles and values of putting the patients first. Next slide. Many of those goals, I think, can actually be accomplished with many of the reforms and changes that we have already been working on and have already been recommending. And so I think part of the work would be to pull those threads together into a kind of a comprehensive and focused and cohesive statement that we could make in our recommendations this year. We've made recommendations around the need to strengthen and expand the state's oversight and compliance and enforcement tools, both at the HPC, but also the Attorney General's office and the Department of Public Health, so that we can include private equity investments in those transactions that are subject to review, so that we can include transactions when providers are selling their real estate, so that those are subject to public review, so that the state may have a process for actually requiring conditions rather than just asking parties to commit to things as part of these reviews. We've talked in past recommendations around strengthening transparency requirements and the need for comprehensive public financial reporting. Part of this could be that, again, recommending the need for revitalizing health planning. And again, not just thinking about the consequences of what's happened, but some of the root causes, and making some recommendations here around the unwarranted price variation and commercial insurance payment differentials that we know that perpetuate inequities in the distribution of healthcare resources. These are all concepts and policies that the Health Policy Commission has championed and has a lot of research and evidence base to back up. And so pulling these together as our statement in response and as a beacon about where we need to go next, I think could be a welcome opportunity at this moment. But I will stop there. And I really want to open it up and to get your feedback and your thoughts about this concept and this idea of using the cost trends report recommendations this year on this specific topic. So I'll stop there.
Thoughts and input on this topic? I'll start us off by saying I think that the timing could not be better, having come to this point as a Commonwealth in understanding what happened with the Steward circumstance, but also what some of the other healthcare providers in our state are facing, and what we can recommend and do going forward to change the circumstances. Thoughts and comments from others?
Deb, I would agree with you. I think these policy recommendations make a lot of sense. I would just add that we almost need a preamble that says the system is really fragile and will continue to be fragile given some of the changes that are anticipated under the Steward bankruptcy, and that sort of delaying action on these recommendations will come with a price.
Yeah, well said. And that, understanding what we do need as a state going forward, I think revitalizing health planning is critically important because every organization, I think, is stretched now. The Steward circumstance will simply stretch them further, or exacerbate that. And so understanding what's really needed going forward is going to be essential.
Yeah, I think it makes I think it makes absolute sense to focus the recommendations around this particular issue. The urgency couldn't be greater. And I want to pay special attention to enforcement, really, because I think the fact that DPH can determine a health service essential and the health system can move forward and with discontinuing that service. I'm thinking of past instances with UMass Memorial and that maternity ward closure, but of course with Steward's recent closures at Kearney and Neshoba, we ought to have more tools at our disposal to stop hospitals and the businesses that operate hospitals from doing whatever they want and exiting without a trace. So I think as much as I think we ought to have all hands on deck and all tools at our disposal to really increase that enforcement, because otherwise, what are we doing?
Thank you. And Commissioner Foley, and then to Commissioner Houdt.
Thank you. Yeah. I want to really appreciate the conversation that we're having today. Overall, it's been a lot to have good information and to hone in on the end about the policy recommendations that I think clearly what we've seen through the Steward crisis is clear need for change and for reform. And I think it's really important that in the previous slide, I think, just talks about addressing the inequities, and it is there with the price variation, but just that one, thank you. Just to correcting the long-standing healthcare market dysfunctions. Like, I feel like we definitely clearly need better tools of oversight and alignment between HPC, the Department of Public Health and DON process, and the Attorney General to make sure like each of those regulatory agencies is aligned in their roles and goals within managing the healthcare market, in particular with a keen focus on private equity and for-profit healthcare. I've said it before, and I'll say it again. At one of our cost trends hearings, we had many of the for-profit providers before us, and I asked, is there implication when you're in a for-profit mode of delivering care, and it's on any implications for a healthcare system? And they said, no, it's just a tax status. Well, I think clearly we've seen that's just not accurate. And so I do think we need more robust tools and oversight for who's owning the hospital systems and what their plans are for them and how to protect workers and consumers, and the financing behind it. I think one of the big takeaways that I have from the Steward healthcare situation currently is that running out of money was a significant issue, and not being able to claw back any of that money and having workers losing 47 years of severance to greed. Like, that should not happen in our healthcare system. And then the implications for patients and folks wanting to leave healthcare because of their experiences. So clearly we need a better system of regulation and oversight, and ability to claw back and protect consumers and workers in our communities. But also, I think it's really important we don't lose sight that there was conditions under which Steward took advantage of the dysfunction in our market and put us in a really difficult situation. And so if we just do the regulatory part and not the dysfunction in our system and the real struggles many of our healthcare providers are facing right now, I think we're missing the full story of how this came to be in the first place. And so I think it's urgently important for the HPC to double down on these recommendations within the lessons that we've learned. Maybe having some discussions with folks about ideas and suggestions that they have and what they learned from this process. There's many people involved in this that want to do good things for the healthcare market, and push with urgency these necessary changes. And I'm sure there's others that we haven't thought of. And I think I don't want to have a system preparing for what we just went through. Well, how are we anticipating the next problems? Because it's going to look and feel differently. So I certainly support these recommendations, and we want to reinforce, I think, the healthcare market dysfunctions that need to be addressed to not create an opportunity for predatory actors to come into our system, which we're seeing not just in hospitals, we're also seeing home care and long-term care. That we have to look at this as a healthcare system, not as individual parts. So appreciate the recommendations and look forward to how the Health Policy Commission can support the decision makers and the legislators and our leaders to move forward with these necessary recommendations and policy changes. Thanks.
Thank you. Commissioner Houdt?
Yeah, we go to the next slide. revitalizing the health planning, and that sort of aligns with goal 7 that we had before about aligning supply and distribution of services with community need. I think one thing that the Steward episode has caused me to reflect on is reimagining some of our healthcare delivery. And so we have 2 hospitals now that we no longer have, essentially, and their licenses evaporate, but we have buildings and we have need in those areas. And I think part of what HPC can do is, based on our data and cost and analysis of community needs, is reimagine what those institutions could be to those communities. May not be a full comprehensive hospital, but it may be an emergency room in that area and basic surgical rescue techniques before people are transported, because in Neshoba, they're so isolated that patients will die because they won't be able to get to an emergency room in time, and different issues relative to Kearney. But those are buildings that are there that can be used. And I think it would be a great use of our data and research and recommendations to recommend uses for those facilities so that the community needs are still being met.
Sorry, I was muted. Other thoughts or comments? I'll just, note again that we'll have an opportunity to discuss this with our advisory committee soon and get some of that input that Tim was also recommending in terms of understanding reactions and thoughts on the recommendations. Great. Well, as David said, this is our first opportunity to talk about the report and recommendations. It won't be our last. We'll get further input over the coming weeks and then have an opportunity to review this at the next board meeting. But if you do have other thoughts or input for the team as you're digesting this, please reach out to David.
Thank you. Thank you, commissioners, and thank you for those comments and the discussion. It's just been such a great meeting to be a part of this dialogue today. And don't worry, Deb, I will be in touch with them. You will be hearing from me, and as we put all of this together and put this together, I absolutely want all of your input on this. This is a statement from all of us, the commission, and I think will be a really important statement this year that we will then, I think, take forward into our cost trends hearing later this fall as well. So thank you. And I think we're ready to move on to our next agenda item, which I am very happy to turn over to our Deputy Executive Director, Colleen Elstermeyer.
Great. Thanks, Director Seltz. Well, yes, you can show the first slide here. I am really excited to formally announce to our Board of Commissioners and to the public a new initiative at the HPC, the HPC's Behavioral Health Workforce Center, which we launched officially this summer in partnership with the Executive Office of Health and Human Services. The goal of this center is to strengthen the state's capacity to identify and respond to current and ongoing behavioral health workforce needs. So, how do we recruit, retain, develop a diverse, experienced behavioral health workforce that can provide linguistically and culturally tailored care across the Commonwealth while prioritizing underserved and rural communities? So this new center, while being housed at the HPC, is really part of the Healy-Driscoll administration's comprehensive suite of behavioral health workforce initiatives. You'll see on this slide, this new center and the associated studies are funded by the Behavioral Health Trust Fund. So there's a line item appropriation which directs this work And the initiative is also modeled after legislation that's been sponsored by Senator Keenan and Representative Kay Khan to establish this sort of behavioral health workforce, center of excellence, if you will, this research hub. So yes, we're kicking off the establishment of this center now. First things first has been to hire staff. And really shortly, I'll turn it over to Amy Doyle, our inaugural director. And then obviously, stakeholder engagement and kicking off the research activities such as identifying data needs. What do we really need to start these studies? So also are all in the top initial priorities for the center. So on the next slide, please, talking a little bit more about what the goal of the center is. So the mission, really to gain insight into the BH workforce crisis in Massachusetts, and then use those lessons to advance evidence-based strategies for state policymaking and policymakers. So to really strengthen the state's capacity as a whole to ID and then respond to BH workforce needs. So want to acknowledge right at the top all of the private and public sector work that's already happening in this space. At the HPC, we really understand and I really think prioritize the importance of working alongside our interagency partners, all the healthcare stakeholders, all these providers to support their ongoing work as we all push towards the goal of, retaining, recruiting, developing this diverse experience. Behavioral health workforce. So finally on this slide, I just, a brief list here, just including some examples of policy solutions that the center is going to explore, streamlining licensure, barriers to certification, expanding the role of skilled non-licensed professionals, fostering new partnerships with higher ed, which, such a strong presence here in Massachusetts and all of the academic institutions. So those are some of the policy solutions that we're thinking about. But, of course, that's jumping ahead. On the next slide, it's still very much in the initial concepts phase and welcome any feedback and input that our commissioners have. But on this side, these are just some initial development thoughts on how we will accomplish this work, like which strategies are we going to employ to really meet our mission here. So, research and data, stakeholder engagement and dissemination, policy regulatory recommendations, and partnerships for action and reforms. We believe the center fits squarely into our mission and also leverages all of these things, the HPC's research and policy expertise and all of our existing stakeholder relationships. So truly in our wheelhouse. And the key and the goal, as I've said, is to really work with stakeholders to moving forward now to refine and focus the mission as well as these strategies. So more to come here. This is really just an initial sort of concepts slide that I wanted to show you. But, these concepts do feel right for the first priorities as we really look into standing up the center and standing up the work and getting it started and really trying to create this behavioral health workforce research hub. So on the next slide, I am now really pleased to turn this presentation and frankly, this entire work stream over to Amy Doyle, our brand new director of the Behavioral Health Workforce Center. Amy's going to share more background on, the critical need for the center and our research agenda. Just want to highlight Amy's an adjunct lecturer in social welfare policy at the BU School of Social Work. Joins the HPC directly from Mass Health, where she was Deputy Director of Policy for the Office of Accountable Care and Behavioral Health. And Amy has over 10 years of experience working directly with BH providers and policymakers, in addition to working in the field herself. So Amy, over to you. Welcome.
Thank you for that introduction. Really appreciate it. I'm very excited to be here and to be meeting all of the commissioners. And super excited to be joining the Health Policy Commission. This is just my third week, I believe, in leading, but being here to lead the new Behavioral Health Workforce Center for Massachusetts is just such an exciting opportunity. If we can go to the next slide, please. I'm going to share some key points and priority areas that are top of mind for us as we dive into this work and why we believe it's a critical time for the state to be investing in strengthening the behavioral health workforce through policy solutions that are driven by research and data. So kicking things off with some of that data. For the last several years, we've been experiencing a rapidly increasing demand for behavioral health and substance use services, which of course, as we know, was worsened by the COVID pandemic. And while Massachusetts does have a relatively high supply of providers compared to other states, individuals and families have recently reported some staggering rates of unmet behavioral health needs. They're experiencing long waiting times for appointments, and if they're able to, many are needing to pay for services completely out of pocket to be able to get the care that they need. One data point on this slide I do want to draw your attention to is that of the 18% of households with at least one child needing behavioral health care, over 3/4 of those families have reported having difficulty accessing care or being completely unable to access care. An example of this is in-home therapy, which we know is an extremely critical service and brings some equity to care access for children and families. But that was recently, just in 2023, was found to have an average wait time in Massachusetts of about 20 to 26 weeks. So some really terrifying numbers there in terms of just the barriers to accessing care. Next slide. We can connect these access challenges directly to the workforce crisis. An unfortunate pattern that we've been observing is that providers are leaving community-based settings in favor of going to places where they can exclusively accept private pay or just accept a limited number of insurance plans, oftentimes only accepting commercial insurance and not accepting mass health. And further, we're seeing clinicians and other behavioral health professionals leaving the field entirely and leaving at a faster pace than new workers are choosing to join the field. This is directly contributing to the behavioral healthcare delivery crisis at the systems level. And the impact that we're seeing, as demonstrated here, is that people in need of treatment are getting stuck across all levels of care. Examples of this include, as we've already discussed, boarding in the emergency department due to lack of available inpatient beds, and then waiting longer than actually clinically necessary to be discharged from those beds due to staffing shortages, not being able to get into intensive outpatient care or other facilities, or waiting months on end to get access to therapy or other services and resources within their own communities. And this is especially true when care is needed in languages other than English. So again, really driving the point home that the access challenges exist for everyone, but we're seeing disproportionate effects for communities of color and underserved communities where providers are even existing even greater shortages. With all of this in mind, it's become very clear that further offering greater supports to and diversifying the behavioral health workforce is one of the most important strategies that we can employ at this time for improving access to care overall. Next slide. And just to quickly preview this, as I mentioned at the beginning, we're focused on developing solutions and policy recommendations that are driven by data, which we will achieve through our research agenda for the center. The activities listed here have been already requested of us by the legislature, and it will be the jumping off point for us as we establish the center as the behavioral health workforce data hub for Massachusetts. More to come on these studies, these projects, as we scope them out and make our plan for completing them among some other related projects. And with that, I will turn it back to Colleen to discuss our next steps.
Great. Thank you, Amy. So we're going to be announcing more details in the coming weeks about this, but we're actually launching a procurement process to seek members for the official Behavioral Health Workforce Center Advisory Group. So if you're interested in that, all the information is not available yet, but will be available on our new webpage for the Workforce Center, which is masshpc.gov/BH-workforce. And it's also featured on our homepage if you didn't get any of that, masshpc.gov. You can also sign up to receive updates on the center's work, which will include job postings, information on the procurement, information on any public meetings we have. We've launched a new mailing list for the center. So there's a sign up button right on the bottom of that webpage I just mentioned. So make sure you click on that and sign up. So yeah, I'm happy to take any questions about the center if there are any before I turn it over to another colleague to talk about a particular area of research in the BH space. But, thank you to our incredible HPC staff who've been working to get this up and running. Shout out to our Commissioner Behavioral Health expert, Commissioner Cohen, who will be looking to for a great deal of guidance and assistance as we really get underway here. And, also all the stakeholders we've already met with during the pre-launch phase to help guide us and get us to this point already. So we're looking forward to many more discussions ahead. So Amy and I are happy to take any questions if anybody has any. Commissioner.
Great. Looks like Commissioner.
Oh yeah,
Blake.
thank you, Chair.
Thank you. Not a specific question so much, Colleen, as to just say to you, Amy, welcome aboard. I'm thrilled that you're here. And I think we're all excited about the potential work and the potential impact that you and the group, the center can have on behavioral and mental health. Especially, I have a particular interest in children in this area. So I'm very interested in what you get up to and what you propose. So thank you for joining us, and we look forward to working with you.
Thank you. I really appreciate that, and definitely sharing your excitement. And most of my experience actually is also in children and families prior to joining Mass Health. So that will certainly be an area that I would love to focus on and talk to you more about.
Terrific.
Not a question, but a comment, and it's actually to Colleen. I had the opportunity to spend time with Amy. Great hire. Congratulations.
Thank you. It's my particular skill set.
Hi.
All right.
Another
go
quick
ahead.
comment, and also welcome, Amy. So just quickly, I guess as more details become available, would love to know more about the procurement process for the Behavioral Health Workforce Advisory Group and who would be on that advisory board. I think that's very important, especially considering the disproportionate manner in which people of color are impacted by behavioral health issues, and then also face disproportionate challenges accessing behavioral health care. And then I also want to mention, the difficulties in really convincing hospital operators and other providers to even provide behavioral health services, especially in low income and low wealth communities. So similar to maternity care and hospital level obstetrics, these are money losers for hospitals, and especially for-profit operators. They tend to be, you're hard pressed to get them to want to offer these services in low income communities. So I just, would beg us to consider how we're going to make sure in the planning process that these services are available in the most vulnerable communities, because, I can't help but think about Kearney's recent closure and really the vacuum that will leave in Boston. So thank you so much.
Yes, absolutely. Thank you for those comments. I think just one response to the procurement process, why we've decided to go that route, there is some guidance in the governing legislation and appropriation about who should be on this advisory group. And so we're going to take that into consideration, but we felt that the most fair process was to put it out there and have everyone apply. So, self-select, we want to be on this group. It's not, how we always handle some of these advisory groups. Sometimes we just go out and say, would you like to join? So we're trying to make it as statewide as possible. So we'll definitely be back in touch with you about that. So thank you. I also wanted to give one other shout out, because I see her back here, to Undersecretary Sung, who, if you recall, we talked about this many, many months ago. So happy to see it finally come to fruition. Appreciate our EOHHS partners on this. So
Holly, thank you so much for the HPC's partnership. This is just really a enormous collective effort, much needed, and much gratitude to the commissioners and to the HPC staff.
Yeah, I mean, this is one small part of the administration's activities in this area. They're doing, a massive loan repayment program, all kinds of other activities funded by the Behavioral Health Trust Fund. So this is really really unique, a huge opportunity here. So, great. So finally, we have done work in the workforce space, and including a report and an event last year. When we have other research studies underway in the behavioral health space as well. Behavioral health related ED boarding is coming up. Pediatric behavioral health planning is coming up. And then in particular, we have a new analysis on the role of behavioral health managers in the Commonwealth. So I'm going to turn it over to Nancy Ryan, our Director of Office of Patient Protection, who's going to be talking about this upcoming analysis. Really important work. Nancy?
Thank you, Colleen. As Colleen said, I'm going to be talking about a new report that the HPC will be issuing soon. The HPC was directed by the legislature to examine the effects of behavioral health managers on the Massachusetts health care market. And in this context, a behavioral health manager is a company that contracts with a health plan to provide or arrange for the provision of behavioral health services for health plan members. These entities are sometimes referred to as carve-outs or behavioral health carve-outs. And in this report, we identify the behavioral health managers used in the Commonwealth and for what services, summarize the regulatory landscape in Massachusetts and other states, bring to light stakeholder perspectives on the use of behavioral health managers, and review some quality data for a comparative analysis. This report sort of sets the groundwork for what the current status is in Massachusetts of behavioral health managers. And the report concludes with some recommendations for ways to improve the provision of behavioral health care services when behavioral health managers are involved. We go on to the next slide. As you can see, this slide shows a visual representation of the relationships between health plans. In this case, on this slide, commercial health plans and Mass Health and their behavioral health managers in Massachusetts as of today. These contractual relationships have remained relatively stable over time. You may notice the largest sort of recent shift is Harvard Pilgrim Healthcare transitioning from using Optum to moving its behavioral health management in-house in late 2023. And we just wanted to provide a quick sort of summary of our key findings and look, to have this report more closely looked at once we release it. But most health plans in Massachusetts use a behavioral health manager for at least some services. The services that behavioral health managers provide really varies from plan to plan and is based on sort of the needs of the plan at the time of contracting. Most typically, the services do include providing a network of behavioral health providers. This was often cited as sort of the most important or most useful service that a behavioral health manager can provide. They also usually provide utilization review, claims processing, and reporting. To a lesser degree, there's case management that they do provide, but some plans sort of more and more are taking case management in-house at an effort to sort of more integrate those services with physical health services. As part of the report, we met with many different stakeholders, and the experiences with behavioral health managers varied based on the experiences of those stakeholders. The report really tries to capture this variability and outline some of the advantages and disadvantages as seen by payers, providers, and consumers. In reviewing the quality data, we did not find significant difference in HEDIS quality measures between plans that used a behavioral health manager versus those that did not. Overall, I think the report provides a good understanding of what behavioral health managers are, what services they provide, how the relationships with health plans are structured in Massachusetts, and the current regulatory landscape, as well as a look into how other states regulate these entities, and the quality analysis. The report also makes policy recommendations to improve, the delivery of behavioral health and have it be better integrated into, physical health care delivery, even when behavioral health managers are involved. So that's kind of just a quick overview. I'm happy to take any questions, but definitely look forward to sharing the report with commissioners and having the report also released to the public.
Great, thanks, Nancy.
Thank you. Any questions for Nancy? We'll look forward to the full report. Any
All right.
questions or comments? If not, thank you on this, and we'll add my welcome to Amy. Look forward to the next steps on development.
Great.
And now for our last agenda item, we'll move to the executive director's report.
Thank you so much, Chair DeVoe. And I am going to turn it right over to my colleague, Kate Scarborough-Mills, who is going to talk about the material change notices we've received since the last meeting. Kate?
Great. Thank you so much, Colleen. Hello again, commissioners. You all know this slide well, which summarizes the material change notices we've received to date. As David noted earlier, we currently have more transaction reviews live right now than we've ever had at any point in HPC's history. And in total, since 2013, we've now received notice of 180 different provider transactions. Of these, transactions involving the formation of contracting entities still remain the most frequent. Next slide, please. We continue to have one active cost and market impact review regarding the proposed transaction between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty physicians at Beth Israel Deaconess Medical Center. As you know, that transaction involves a new clinical affiliation between Dana-Farber and Beth Israel and the physicians following the termination of the longstanding affiliation between Dana-Farber and Mass General Brigham, as well as the establishment of a new freestanding cancer hospital in Boston for adult cancer patients. Just to update folks on where we are in that process, we are continuing to work very closely with the parties as they finalize providing information to us in response to our information requests. That production to us is not yet substantially complete. So on the next slide, you'll see an overall timeline, but please know that we are here as marked in the little orange star. We are temporarily paused in terms of the timeline while we're waiting for the parties to complete production to us. And we very much appreciate the parties' continued collaboration with us to provide the necessary information for our review. And we look forward to discussing our findings in depth with all of you in the coming months. On the next slide, additionally, since our last board meeting in July, the HPC has elected not to proceed to a cost and market impact review on 3 transactions that you see summarized here. First, the proposed acquisition of same-day Surgicare of New England by South Coast Health Systems. So prior to the transaction, South Coast, which includes St. Luke's, Charlton Memorial, and Toby Hospitals, owned a 49% share of same-day Surgicare, and under the proposed transaction, South Coast was proposing to acquire the remainder of same-day Surgicare and continue to operate it as a freestanding ambulatory surgery center. In the HPC's preliminary review, we did find some limited potential from cost and market impacts as SDS joined South Coast as a wholly owned subsidiary. There could be some small reduction in competition for certain outpatient surgery services, but there's also a potential for some savings if the parties achieve their goals of diverting more care away from the hospital settings to the lower cost ASC. Any potential spending impacts, though, would be limited by the relatively small volumes we're talking about. We did not review any evidence suggesting a negative impact on quality or access to care. Second, we reviewed the proposed joint venture between BMC Health System and Telica Imaging. BMC Health System, which is the parent of Boston Medical Center, and Telica Imaging proposed to enter into a joint venture in which they would form a new entity, Telica Imaging of Massachusetts, which would own and operate up to 3 new licensed imaging clinics offering MR and CT services in the community. Telica Imaging is owned by the nonprofit Intermountain Health and currently has locations in Utah and Idaho, and has recently opened 2 locations in New Hampshire. In our preliminary review of this transaction, we found that it was likely to have a limited impact on healthcare spending in the Commonwealth. We did confirm that the clinics will be independently licensed, freestanding clinics that would not be reimbursed as more costly hospital outpatient departments. And again, we did not review any evidence that would indicate that there is a potential risk to the quality of services or access to services. The transaction may also positively impact access to MR and CT services for BMC-affiliated patients and other individuals residing in the communities where those clinics will be located. And finally, we reviewed the proposed acquisition of certain assets of BioReference Health, a national laboratory testing company and subsidiary of OPKO Health, by the Laboratory Corporation of America Holdings, which we refer to as LabCorp. Under the proposed transaction, LabCorp would acquire the national clinical diagnostic and women's reproductive health-related assets of BioReference nationally. That includes 2 specimen collection stations here in Massachusetts in North Andover and Hopedale. And in our preliminary examination, we found limited potential for impacts on spending and market dynamics in Massachusetts, as BioReference had less than 0.5% of commercial market share for laboratory services in our state. We did not review evidence indicating that the transaction is likely to negatively impact access or quality of care, but we are expecting to continue to closely monitor LabCorp's pricing and other behavior over time, as they've been growing somewhat quickly in Massachusetts in recent years. I will pause there if there are questions on any of those 3 material change notices for which we closed review. Seeing none, on the next slide. Additionally, since our last meeting in July, notices of the proposed sale of the Steward Physician Network Stewardship Health to Optum, which was initially filed with the HPC in March, has now been abandoned by the parties and officially withdrawn from the HPC. And on the next slide, since our last board meeting, we've also received material change notices on 4 transactions beyond those Steward transactions that Megan already described, which you see summarized on this and the next slide. So first, the proposed formation of a new contracting entity in Massachusetts, Optum Health Networks by United Health Group, which will negotiate risk contracts on behalf of independent physicians and facilities seeking to participate in the Optum Care Network. Second, the proposed creation of Northeast Orthopedic Alliance, as well as an affiliated management services organization by 4 existing orthopedic group practices in Massachusetts and New Hampshire, which would be planning to consolidate their operations under that new corporate structure. Third, a proposed contracting affiliation between Mass General Brigham and Healthcare South, which is an internal medicine and pediatric primary care practice with 9 locations on the South Shore, which currently is a contracting affiliate of Tufts Medicine Integrated Network, which would be now proposing to leave the Tufts Network and join the Mass General Brigham Network. And finally, on the next slide, the proposed acquisition of Vibra Hospital of Western Massachusetts, which is the for-profit owner and operator of both an inpatient long-term acute care hospital and a skilled nursing facility in Rochdale, Massachusetts by Everest Hospital, LLC, which is a newly formed Massachusetts corporation in coordination with the investment group, Neilk Equities, LLC. And then on the next slide, I'll of course note that these are in addition to all of the Steward reviews that Megan discussed earlier, as well as the ongoing CMIR. And we will be in touch with commissioners on findings and recommendations regarding all of these as soon as that information is available. And finally, on the next slide, I wanted to update commissioners that we are also issuing guidance today relating to material change notice filings and when those are required in an employment context. Under our MCN regulations, affiliations that increase the net patient service revenue of a provider by 10 million or more are noticed to the HPC. Our regulations say that this can include the employment of multiple healthcare professionals from the same provider organization, provided that it meets that financial threshold. We've received some questions from providers about exactly how that process works in an employment context. like who needs to file and what information needs to be disclosed publicly. So this document, which is now available on our website, provides some public guidance on those issues, clarifying, for example, that a provider should file with the HPC whenever it is clear that it expects to hire a sufficient number of healthcare professionals within a given 12-month period, that it will reach that 10 million threshold. However, I do want to acknowledge that a lot of the details matter when it comes to these transactions. So we always urge providers to reach out to us anytime if they have questions about our process, if they have questions about whether a filing is required, they can always reach out to this email, hpcnotice@mass.gov. And we'll pause there in case there are questions on any of those pending reviews or the new FAQ.
Thanks, Kate. Appreciate that. Okay. On the next slide, I'm going to turn it back to my colleague, Director David Seltz, to close out because you were at this event, David, weren't you?
Yes, I was. A very exciting, very celebratory bill signing for this landmark, dare I say, maternal health legislation that was passed and signed by the governor since the last board meeting. This was a really great piece of legislation that, although it was not passed before the end of the legislative session, legislators were able to come to a final agreement and pass it unanimously in informal sessions. The law does a lot of wonderful things, including expanding coverage for midwifery, doulas, creates a pathway for more birth centers in Massachusetts, expands coverage for screening and treatment for postpartum depression. It also has a couple of new roles for the HPC. There is a new task force on maternal health access and birthing patient safety, which will be co-chaired by the Health Policy Commission and the Department of Public Health, and has a really interesting mandate. And so we're really looking forward to standing that up. It also adds the HPC to an existing maternal mortality and morbidity review committee, which will allow the HPC further insight into some of the data that's being collected in that area. There was also important legislation on the long-term care sector, which enhances oversight in the nursing home sector, among many other provisions. Here too, there's a research project or a research mandate for the HPC, I should say, charging us with looking at the impact of the Medicare Shared Savings Program on the financial viability of long-term care facilities in Massachusetts. So we'll be trying to tackle that research mandate, and also adds us as a member of a new task force on financial performance of skilled nursing facilities. Next slide. Our standard recent and upcoming publications will note that since our last board meeting, we did release a new data points on the GLP-1 weight loss drugs presentation that we shared with you earlier this year. So we wrote up all of those findings and released that. That went out since our last board meeting. So check that out. And we have a number of reports on the way. As we heard from Nancy Ryan earlier, the Behavioral Health Managers report on the way, and a number of other reports, as you can see here. Next slide. Okay, upcoming meeting agenda. So, as you have heard many times today, we have a lot going on at the HPC. And there are a lot of transactions under review, a lot of reports to be released, a lot of recommendations to be finalized. So we will need to be adding an additional board meeting this fall. We had previously scheduled our 2 committees to be meeting on October 10th. We are now going to be shifting those 2 committee meetings to a board meeting. We will be meeting next on October 10th for a full board meeting. At this board meeting, we'll be sharing findings from some of of those market reviews, as well as continuing conversation on the cost trends report and recommendations, as well as some other important business items. So please note that important change in our calendar, and for members of the public who follow us, please note that we will have an important meeting on October 10th. Starts at noon, as always. And next slide, please. If you can believe it, we are here back again this fall for our annual healthcare cost trends hearings. Save the date. We are planning for our annual hearing for Thursday, November 14th. We are planning to start bright and early in the morning of November of that day. We have already secured our location at Suffolk University Law School, our longtime home for the healthcare cost trends hearings. We have already opened up our registration, and so encourage members of the public who attend these hearings to already please come and register. Commissioners, obviously we have a lot of planning to do before this hearing, and so you will hear from us early and often as we begin to plan the agenda and the themes and the invited guests for this year's hearing. So mark your calendars and watch this space. And with that, I will turn it over to Chair DeVoe to close us out of today's meeting. Thank you so much.
Thank you. What a meeting. So this was 301. I guess that's going to be a landmark too. This was an incredibly important meeting. Really appreciate the work of the entire team at the HPC that has gone into this meeting, and looking forward to the added meeting in October that will follow up on many of the issues that we introduced and talked about today. Any final questions or thoughts from any commissioners before we close? I don't see any, so I just want to thank everyone, commissioners, and those tuning in from the public for your participation. And thank you.
Thank you all. Have a good day.
You too.